Welcome everyone to today's PHSSR Research in Progress series, Bridging Health and Healthcare. My name is Angie Carmen and I'll be your moderator today. Our topic is Community Health Improvement Plans and Community Health Needs Assessments, moving toward collaborative assessment and community health action. We have two presenters today. Dr. Scott Frank is an associate professor in the Department of Epidemiology and Biostatistics at the School of Medicine at Case Western Reserve University. Dr. Frank directs the Masters of Public Health program and holds an appointment in family medicine. We also have Alexandria Drake. She's the project coordinator for Research Association for Public Health Improvement. It's Ohio's public health practice-based research network that is housed at Case Western Reserve University. Alexandria is also involved in multiple projects designed to measure and improve public health practice. She engages in collaborations to enhance the research quality, manages project logistics, communication, and data collection and analysis. We'll turn the presentation today over to our presenters and invite those of you that are on the webinar to put your questions of the presenters into the chat box, and we'll hold those until after we have introduced and allowed our commentators to speak today. So Dr. Frank and Alexandria, we'll turn the presentation over to you.
All right. Good afternoon, everyone. Thanks for being on the call today. So Scott and I are going to talk about Better Together, Hospitals and Health Departments, Public Health and Medicine. So we quickly just want to say we don't have any disclosures, and we would like to thank the Robert Wood Johnson Foundation for their PHSSR Quick Strike grant, which funded this research. We would also like to acknowledge our RAFI team, as well as our team at the Health Policy Institute of Ohio, who completed this research with us. HPIO was in charge of collecting the data for the hospital documents and then compiled the data into a really nice publication that's in the upper right file that you can look at later. And I know one of them was planning on being on the phone. Reem or Amy, are you on today? All right. Well, we want to make sure we acknowledge them and thank them for all their work and working with us. Oh.
I just got on. I heard you.
I'll add that a number of the slides in this presentation were designed by HPIO for our recent conference that Alexandria will explain later, so thank you to HPIO for the design of those slides.
Yeah. This is a quick overview of our presentation. Today we're going to go through the purpose, the background, the methods, the results, and then we'll have the commentators and some Q&A at the end. So the purpose of this research was to compare and contrast the community health assessment process and priorities led by local health departments and by hospitals in Ohio. So some key terms that we want to review are community health needs assessments, or CHNAs, and community health needs assessment implementation strategies, or CHNAs, which are both hospital documents, and community health assessment CHAs and community health improvement strategy CHIPs, which are both local health department documents. And I also want to note that all CHNAs documents include a CHNA, and in parallel, all CHIP documents include a CHA. They're essentially a more detailed version of the first document. And then the last key term is community health assessment and process and priority quality measurement tool, or the CHAP quality measurement tool. So last Wednesday, the Health Policy Institute of Ohio hosted a forum down in Columbus to essentially go over this research. And at that forum, there were 204 attendees. 65 noted themselves as from hospitals and 68 from local health departments. And then once the forum was over, they held a roundtable discussion, which had 53 participants, 14 from hospitals, 28 from local health departments, and 9 from other organizations. So that was a really, really great event, and it was nice to have all those people together to talk collaboratively about these community health assessments.
One of the comments that I'll make is that everybody who I spoke with agreed that they had never been at a conference that was so evenly divided between hospitals and local health department attendance, which was really a terrific thing.
And so then kind of shifting more into the importance of this research right now, looking at LHD-led CHA-CHIP documents, there's been a big push lately, a big state and national movement to require local health department accreditation. This is especially pertinent in Ohio. Ohio is requiring all LHDs to begin the accreditation process by 2018. And because of this push, there is a big effort to really enhance the consistency of these documents to improve the overall quality. And then in parallel, looking at hospital-led CHNA and CHNIS documents, under the Affordable Care Act, most nonprofit hospitals are required to complete a community health needs assessment or a community health needs implementation strategy document in order to receive funding. And then kind of taking a step back and looking more broadly at these documents, very little has been done to look at these variations and priorities in the past and seeing how community characteristics might influence these changes and these differences in priorities. So with that, I'm going to pass it over to Scott.
At the recent conference, we had the pleasure of having Dr. Kevin Barnett from the Public Health Institute speak, and these slides have been adapted from his presentation looking at the final IRS regulations relating to community health needs assessments, or CHNAs. And we include these slides in particular because it influences both policy and priorities that have been selected that we'll be discussing as we go through our presentation. The first of these points out that the CHNA cycles do require input from persons representing broad interests of the community anew with each new CHNA, and that priorities be set with input from those outside sources. They also require that such input be documented and that there be a focus on disparities as part of the final document. In addition, there's a requirement that social determinants of health be addressed, financial and other barriers to care, or address social, behavioral, environmental factors that influence the health of the community. Finally, future CHNAs will require that evaluation of what was accomplished from the previous CHNA be included, but this is more moving forward than in what really represents a first cycle based on these requirements. So this is what we've accomplished. 189 nonprofit or government hospitals conducted 170 CHNAs and 80 improvement strategies. Among our 124 local health departments, as of September 2014, we identified 110 CHAs and 65 CHIPs. For both of these, we believe that the 170 and the 110 represent whole samples, and that those who didn't, 19 for hospitals that we don't have, 19 for hospitals, 14 for local health departments, represent either documents that were unavailable or were not done. For local health departments, we did confirm that the 14 health departments that we did not review, in fact, had not completed a CHA or CHIP in the past 5 years. This looks at a bit at the nature of the process. Cross-jurisdictional CHIPs occurred in a little bit more than a third of the health department processes, and you can see also the collaboration among hospitals. This is within group rather than between groups with local health departments and hospitals that we're demonstrating here. 80% had 2 or more hospital facilities, and a little bit more than a third collaborated with at least one hospital outside of its own health system. We took care to demonstrate the extent of collaboration between local health departments and hospitals, and did so from each side of the equation. You can see here, this is the percent of hospitals reporting local health department collaboration, and 11% had no local health department collaboration. The most frequent collaboration involved being in focus groups or key informant interviews, though CHNA partnership was reported in 46% of cases. In 19% of cases, it was reported that there was a joint CHNA document. For local health departments, 17% had no involvement. The provision of secondary data from hospitals was the most commonly endorsed area among the health departments, with partnership and leadership roles having a significant number of endorsers as well. The degree of collaboration was less as it moved towards the implementation strategy. You can see the numbers here, and less for CHIP than it was for CHAS. Again, you can see the numbers here. Examining process and quality allows us to compare and contrast the community health assessment led by hospitals using the Ohio Community Health Assessment Process and Priority Quality Measurement Tool. This is an adaptation of the Wisconsin CHIP, Community Health Improvement Plan and Process Quality Measurement Tool. This instrument was adapted to allow direct comparison between local health departments and hospital community health assessment processes, and examine both within groups for local health departments and hospitals and between groups. Our final instrument is organized similarly to the Wisconsin tool, with some notable differences. Each of us had general or foundational items about working together. There were more items on the Wisconsin tool about working together than on the local health department or on the Ohio tool. This in large part is because certain items in the working together category didn't translate well to hospitals. The assessment items are approximately the same. We've reorganized things into a prioritization category and implementation. There's a category in the Wisconsin tool on evidence-based tools, which we've integrated into other sections, primarily implementation in our tool, and a similar number of evaluation items. Overall, we had 43 items on our CHAP tool, and there were 46 items on the Wisconsin version. So this gives a sense of how things looked within the local health department group to start. The highest quality means were demonstrated in combined health departments, with county health departments having the lowest quality measurement tool mean. There was no difference based on whether a Board of Health was involved, and 64% of the local health departments not conducting a CHA were county health departments. Having said that, more than 80% of the county health departments did complete a CHA. This looks at quality by jurisdictional size, and you can see that the mean quality score is lower in the smaller health departments and highest in the larger health departments. There was no difference in quality measurement based on whether the process was a single health department or cross-jurisdictional. 79% of health departments not conducting a CHA were in the small jurisdictions, but again, more than a quarter of the health departments that fit these categories did in fact conduct CHAs or CHIPs. This looks at the total budget, and you can see here that the highest quality mean was by the health departments with the largest budget. But when we looked at the budget on a per capita basis, there was no difference in quality measurement that was noticed. 57% of the local health departments not conducting a CHA had budgets of less than $900,000. But again, most of those departments did in fact conduct a CHA or CHIP. Looking at the same sorts of issues within the hospital group, found really only one difference in the quality measurement tool, and that is if there was collaboration between hospitals with an identical document issued by both, the quality measurement score was highest, and lowest if there was a small joint component. There was no difference in quality in the quality metric based on hospital type, financial size of the hospital, the net community benefit, total beds in the hospital, admissions, outpatient visits, or membership in a group health system. This slide, I will tell you right from the start that we have our legend reversed on this. So the darker color of blue is actually health departments, and the lighter color is hospitals. And what this demonstrates is that local health departments had higher mean quality scores in the foundational questions, working together, implementation, and the total quality metric score, while hospitals had somewhat higher scores for assessment, though that's not a significant difference, and significantly higher scores for prioritization. As we show this slide, might harken back to the comment earlier about the requirements of the IRS and now ACA, which include prioritization being required. The next series of slides are tables that you can look at in more detail later. We'll highlight some findings, and one of the motivations of this set of slides is for you to get a sense of what items were included in the different components of the quality measurement tool, and of course the difference between hospitals and health departments for these items. Again, I'll reinforce that these represent abstractions from available documents, and therefore are limited by the extent to which the documents included information that is measured in our tool. So I'll highlight here that health departments were much more likely to use a formal model or parts of models in guiding their process, and also more likely for specific staff to be involved or designated for the process. In the working together area, we'll highlight that stakeholders were more likely to define the purpose, mission, vision for the process, and that documentation of current collaborations addressing specific issues were more likely to happen for health departments, and guiding principles or shared values were much more likely to be identified. There's a question that's come up on our chat regarding the scale for the quality measurement tool. Each item was graded 0 to 4, so the scale would be on that scale of 0 to 4. In the assessment section, these are selected items. There were too many items to include in the slide. We've noted here some of those areas where the hospitals did significantly better. This includes descriptions of specific populations. It includes descriptions of vulnerable populations. It includes health disparities or the health equity issue. This was counterintuitive to me when I first saw it. I thought health departments would be more likely to describe health disparity or health equity issues, but the requirement that that be done in the IRS rules might explain some of that difference. Again, it was counterintuitive to me that hospitals were more likely to describe community assets and resources than health departments, but that is the finding that we had. In terms of prioritization, again, you can see why hospitals scored higher here. They were more likely to use criteria established and agreed upon by the stakeholder group than health departments were. and their priorities were more easily identifiable to the general public as priorities on their websites. Again, for implementation, there were too many items to include all, so we've included selected items, and here we'll highlight the difference with health departments being much more likely to identify evidence-informed strategies, more likely to have measurable objectives with time-framed targets, more likely to have an action plan that either exists or is under construction, and more likely to identify individuals and organizations that have accepted responsibility for implementing strategies. So key findings related to process include that quality is better in larger jurisdictions with larger budgets. Quality is not influenced by the presence of a board of health or conducting cross-jurisdictional CHOPS. Among hospitals, there's little difference in quality based on hospital structure or financing. Local health department assessment process was more likely to be grounded in theoretical and evidence-based frameworks, more likely to define a mission or vision, more likely to include implementation planning, have broader stakeholder participation, and conduct health policy activity. Hospital community health assessment was more likely to address community asset, health equity, and vulnerable populations, choose health priorities utilizing criteria, and provide community health assessment information to the stakeholders who are setting the priorities. The next section of our presentation emphasizes the level of local health department hospital collaboration and its relationship to the process quality. You'll remember I showed the items that contributed to this metric earlier, and you can see here a direct linear kind of relationship between those health departments who had no hospital collaboration and those, the final set of bars here at the bottom should be high, so none, moderate, high, with the highest quality metric mean being for the highest extent of hospital and health department collaboration. The same relationship existed to a lesser extent for hospitals with higher quality of the hospital CHNAs when health departments were involved. What matters in collaboration is equally important. Demonstrating that collaboration results in better quality documents is of a high degree of importance, but we also looked at each of the items individually and demonstrated that if all we do is provide secondary data, it doesn't improve quality. If all we do is involve the other in focus groups or as key informants, it doesn't influence quality. And you'll remember that those were the two most often endorsed by each. It mattered, however, if there was partnership in data collection, if the other group was involved in the prioritization process, if the process was considered a partnership, and if there was a leadership role for the contralateral group in each of the processes. Leadership role was defined as membership on a steering or executive committee. So what we hope you'll remember from this is that hospitals and local health departments bring different skills and perspectives to community health assessment, that these differences appear to be complementary. Evidence supports that quality of community health assessment process improves with meaningful collaboration. Next, we're going to quickly review the nature of health priorities identified by hospitals and health departments. For this component of our project, we clustered different possible health priorities into health conditions, health behaviors, community conditions, and health systems, and you can see the number of items included for each. This represents the nature of these categories and what was included in each of the categories. I'll mention specifically that the chronic disease item under health behaviors really refers to chronic disease management, and that under health conditions it's listed as substance abuse. We refer to that through other slides as addiction, and it's an orientation towards the condition of addiction and or treatment of addiction, rather than prevention of substance abuse, which is included under health behaviors. This represents the combined hospital and health department top 12 priorities. It includes obesity at the top, and you can see the different rankings of the different priorities that we offered as options. Again, this is not what the health departments said in a survey were their priorities, but what we were able to document from their documents. As we look at contrast between hospitals and local health departments, I love this slide that identifies that 6 out of the top 10 were shared by both hospitals and health departments, though oriented in different rankings, with obesity and access to medical care really topping the list. But there was an impressive overlap between mental health and substance abuse in this prioritization process as well. So in addition to looking at this from the perspective of conditions, behaviors, and community and health systems, we also sought to, first this is a comparison of how hospitals and local health departments chose priorities. This is the percent of priorities chosen within each of these categories. 39% of the priorities were chosen within the medical condition category by hospitals, while only 1% chose priorities relating to community conditions affecting health. For health departments, you'll see that we were much more likely to be oriented towards health behaviors, community conditions, and health systems, somewhat more likely to be oriented towards the health systems. So in addition to looking at it in these categories, we also created clusters because across these different categories, different clusters of related activities occurred. So the obesity cluster, for example, includes not just obesity, but physical activity and nutrition and the food environment, while the access cluster includes both access to medical care and access to behavioral health care. We also did a condition cluster, and this is the way the clusters were identified by hospitals and health departments. You can see, again, the hospitals with a much higher selection of medical conditions. The behavioral cluster actually was higher among hospitals than health departments. For the access cluster, again, higher among health departments than local health departments, and the obesity cluster was about the same. Again, this represents the percent of items chosen within each of these clusters. So to remember from this, we hope you'll remember that there's a wide variety of the extent of collaboration between hospitals and health departments across the state, that collaborations between hospitals and health departments is associated with higher quality. Health priorities are more likely to focus on medical conditions, while local health departments more likely to focus on community conditions and health behaviors. Most prominent community health priorities are related to obesity, access to care, and behavioral health. Quickly to review the strengths of our project, this was a large whole sample that crossed public health and health systems boundaries. It involved a comprehensive approach to that crossing of boundaries, and utilized a standard abstraction protocol adapted from a previously successful model. Limitations include that our findings are based only on the information available in documents, not necessarily what was actually done. that some items were not effective across local health department hospital boundaries and therefore were excluded, and that analysis was based on the stage of the community health assessment project that each hospital and health department was involved with at the time and do not necessarily represent final products. There's somebody who has not muted their phone and you're coming through. If you'd be careful to do that, we'd appreciate it. So to wrap up, we'll say that implications for public health include that variation between the CHA-CHIP and CHNA-CHINUS identified priorities demonstrate important differences in perspective and experience, and that these differences appear to be complementary, implying that population health needs would be more effectively served through a collaborative process. So we started out with a slide that asks the question, are we better together? We end our presentation with a slide stating with an exclamation point that we believe that public health and medicine would be better collaborating and that the community would be better served with this collaboration as well. That represents the presentation that we wanted to share with you, and we will turn things over to our commentators and our moderator for the next section of the presentation.
Thank you, Dr. Frank, and to Alexandria for that presentation. We will turn the presentation now over to our commentators. We have Dr. Rosemary Chaudhry, an adjunct professor at the Ashland University College of Nursing and Health. And after Dr. Chaudhry presents, we'll also hear from Dr. Heidi Goet, assistant professor at Case Western Reserve University, School of Medicine, Department of Family Medicine and Community Health. So Dr. Chaudhry, would you like to begin?
I will. Thank you very much. And hello to everybody on the line. I do want to start by saying that I think this is a wonderful study, makes a great contribution to the oh my goodness, I have competition, and to what we know about this important area of collaboration between hospitals and local health departments. And I think that the findings roundtables that we had and hear all the interaction among the health departments, representatives on the hospitals and others. But getting to the commentary part, I think this is an especially important study not only for Ohio, because our health departments are now required to be accredited by 2020. And as you know, most of you know in public health and in other areas that working with community partners is an important criterion for our FAB standards for accreditation. But I think it's also useful for other localities because it's a baseline indicator of what are some good criteria for assessing effective collaborative processes, and how then can we take information area and maybe look at how effective we are at our community level, and also how this information form QI if we do want to improve our process. And so like any good research, this one really brings a lot of things that you think about for next steps. I would be thrilled to see this replicated in other areas with a broader sample, meaning inside other states, and also, particularly in Ohio, looking at this longitudinally, because I can't help but think that as hospitals get more comfortable with the CHNA process, and as local health departments become accredited, again, for us, the rigor in the accreditation standards related to assessment and is really driving a lot of progress the way we do what we do for assessment, and longitudinal component to this wonderful from my perspective. I'd also like to see in next steps qualitative aspects, and by that I mean maybe case studies, especially if you have doing purposeful sampling where you could sample looking at variation. Hospitals and collaborated higher scoring on the assessment tool, those that did not. See what are the differences that qualitative breadth of understanding about what differences make up from the perspectives of the health department and also stakeholders. And I'd also like to see coming out of the qualitative study a look at how important accreditation was to drive with hospitals, CHNA and CHIP. And last, for longitude, I'd love to see the outcomes of the plan that from some of the hospitals, and again, maybe even high school, just to see, where when the rubber meets the road and we want to see how effective this assessment and effort comes to be, how does it as far as health? About all I have to say at this point.
This is Scott Frank. If I can just comment briefly on one of your comments, Rosemary, you really anticipate our next stage in this process. Part of the plan is to do qualitative interviews with top-scoring CHIPs and top-scoring CHAs, because CHAs are always lower scoring than CHIPs since they haven't gone through the entire process. And look at differences between those. In addition to that, the hospitals that are in the jurisdictions of those local health departments would be engaged for the same qualitative interviews. So that is a planned part of our process that we have not yet implemented.
Well, that's super, and in the interest of full disclosure, although I am on the Ohio RAFI board, I truly did not know that this was the case, so this was not a purposeful setup for Scott. But I'm glad to hear that. That's very exciting. Thank you.
I also will say that we can look at the number of health departments that have been accredited, but it wouldn't help to look at those that are in the accreditation process, because the process is to some extent defined by having conducted a CHA or CHIP. It's one of the prerequisites of accreditation, so that wouldn't be effective. We do have a small but sufficient number of Ohio local health departments that have been accredited, and we can add that to our database and to our evaluation. Thank you for that suggestion.
Okay, sure. Thank you.
Thank you, Dr. Chaudhry. Dr. Gullett, would you like to go now?
Hi, this is Heidi Gullett, and I was asked to participate in this with regard to my public health practice role. But again, in the interest of disclosure, I also want to say that I'm a practicing family physician. So for me, this particular study was of real importance on both sides of what I do. And I think we see here in our county how valuable this has been. So even though I wasn't directly involved with this research, Dr. Frank has really helped set off just a wonderful conversation between our hospitals and our local health departments about how collaboration can happen in real and concrete ways. So I wanted to spend just a couple minutes briefly talking about how this preliminary work that you see presented today has really helped move along a process that was already happening in our county, but in a much more rich way. So we have a collaborative in our county called the Health Improvement Partnership Cuyahoga that has a lot of different sectors and stakeholders involved, and was a process of our community health assessment and our current CHIP, which is the first ever countywide community health improvement plan, which will be released in June. And as part of that, there was a very robust process of doing the assessment and some primary data collection and assessment of secondary data sources. And ultimately, 4 key priorities were identified. And one of those was improved collaboration between public health and clinical care, which for those of us in public health and also on the clinical side, I think have really wanted for a long time. And so, can folks hear me? There's like some, led to excellent conversations, and I think provided a catalytic opportunity that we wouldn't have had to have real conversation with our hospital partners. So I wanted to highlight how this particular analysis has really helped us move forward locally.
For more information, please
one of the
contact
things that has
Department
been a
Coordination
challenge,
or
I
call
think, for a long time is that
311
public health and clinical medicine, we speak different languages often, but one of the things that we share in common, and especially now that we have value-based payment reform happening across the country, is that we both need to be speaking in language that helps address population health. And so I think one of the things we see is that alignment and collaboration on these community health needs assessments and community health assessments and the ultimate plans that result from those assessments on both sides, when done together, can really help bring together the conversation of population health in a very meaningful way. And so I really wanted to highlight what I see this work is doing is really starting that conversation to move in a very pragmatic way. So what can we do together to improve the health of our community? And we have that common population health language, I think, to draw upon. So one of the other challenges, I think, is that public health has often spoken, especially local public health, around upstream determinants, social determinants of health, health behavior change. And those are things that sometimes are hard for hospital systems and clinical providers to necessarily deal with, the way that they're trained and the way that they're reimbursed. But I think as we're seeing bigger health system changes happening in our country, we're able to see that this actually isn't a great process for pragmatically addressing the social determinants of health, which we all know affect the health systems in very important ways. But we in public health sometimes, I think, haven't been able to have a seat at some of those same tables to address the clinical outcomes that we see coming from the social determinants. So I find this to be a real catalyst for genuine and meaningful collaboration, and helping to have us at the same table having these discussions, I think, is really important. And we did that, just last week. We were able to have a whole afternoon of talking and being mixed with hospital partners and public health partners to talk about what this means, not just for the large local health departments, but also for the small ones who maybe don't have the same capacity and infrastructure as some of the larger ones. So we came away with some really, I think, interesting insights. The other piece I just wanted to briefly touch on is that I think Rosemary also talked about seeing the next steps, and Scott followed up with some additional insights on this study. But I think one of the other pieces that's exciting to me is seeing some social network analysis done on some of the high-performing groups that were analyzed in this study, because I think that's going to be a really interesting understanding of how those relationships can impact our ability to work better toward population health improvement in the future. So those are sort of the main comments I have. I'm happy to provide any additional insights or answer any questions.
Thank you so much, Dr. Gullett, and we do apologize for the fact that you had a competing background noise there, but we do appreciate
no problem.
Your comment.
I'm learning all about New York, so it's good. I'm trying to listen and talk at the same time, so hopefully I made sense.
I'm sorry about that.
No problem.
We did put into the chat box that if you need to put the webinar on mute, to please use the mute function rather than the on hold function. I think that's what's happening. We're getting someone's on hold messaging there, so we apologize for that. I will open the presentation today to any questions or comments. I think we have someone typing in the chat box, but we can also go ahead and just open the phone lines if someone has a question for either of our presenters or either of our commentators today.
Whether you're a single working mother trying to make...
Okay, let's see. We do have a question. It says, you mentioned that 64% of the local health departments not conducting a CHA were county health departments. 79% of the health departments not conducting a CHA were jurisdictions of less than 50,000, and 57% of the local health departments not conducting a CHA had budgets less than 900,000. Are resource constraints a factor why these local health departments are not conducting a CHA? Has there been any attempt to estimate the cost of conducting a CHA?
Gail Brewer saying Yorker.
So again, if you have a New York, if you're in New York and on this call, please check to make sure you're muted instead of on hold. I'll respond to CB's question. Thank you for the question, CB. We have not made an effort to explicitly document the cost of CHAs and CHIPs. I think that would be very difficult to do. It may be somewhat easier to do for for CHNAs and CHNAs. Amy Stevens may want to comment on that as well. But what I can say is that because per capita budget isn't an issue, I think it's difficult to interpret. I think that part of the issues revolve around rural, urban, micropolitan, and suburban health departments, and we have not yet integrated those categories into our assessment. It is our plan to categorize each of the hospitals and health departments in this fashion as well, and that may help explain some of these differences to a greater extent.
Thank you. We do have another question. This is an individual that's with the AAFP, American Academy of Family Practice, I believe is what that stands for. And we are working on integrating public health and primary care. I'm wondering if you could speak about your thoughts on primary care physicians' role in community health assessment and improvement.
So this is Heidi. Thank you, Kevin, for your question. And my email is also on the slide, and you can download it from the top corner. So I'd love to connect with you offline as well about this issue. But I'm pretty passionate about the role of primary care in these conversations, both the CHA and the CHNA side. So I feel like primary care is really a key vehicle to achieving population health and community health improvement. And I think a lot of times that gets a bit lost in some of the larger health systems discussions. It may depend on where you are geographically, whether that's primary care has a different seat at the table. But where I have been, it has tended to not be necessarily the prominent role I think it deserves. I'm obviously speaking as a family physician, but I'm also speaking as a public health and preventive medicine physician. I feel like the insights that primary care physicians can provide in designing these assessments and then in designing the work plans that flow from them are really key. So I would love to continue the conversation. I know Dr. Frank may have some other insights as well, but I feel like I'm really excited that AAFP has this as a mission, and ASTHO has really been taking the lead on this as well. So thank you for your question. I think it's a really important one.
This is Scott Frank. I explicitly mentioned it, but I'm also a practicing family physician, as well as a practicing public health practitioner. I am the director of a small local health department here in Cuyahoga County, the Shaker Heights Health Department. I would say that two of our steering committee represent primary care physicians, and the other key participant in our process here in Cuyahoga County is called the Better Health Partnership, which is a network of primary care practices involved in quality improvement in primary care, and they've been really a key partner in this process. So what we know is that it can be a really important component, and I would say that the values of primary care and public health probably parallel each other more closely than most disciplines in medicine. Pediatrics might, in fact, follow that same pattern, and to some extent general medicine, but primary care and public health, as has been noted in several other publications, including from the Institute of Medicine, really are key actors in the solutions to the healthcare problems in the U.S. And formal involvement of family medicine, or primary care, I should say, as a discipline in the community health assessment process would benefit everyone.
We do have another question. Could you explain a little more about the data collection and analysis process?
I'm going to ask Amy Stevens to first answer this question, and I'm happy to follow up on any issues that are pertinent. Is it Reem who's on the line rather than Amy? Okay, I'll go ahead and respond then. We have an abstraction tool. The abstractors were trained to use that tool, We did inter-rater reliability testing in our early stages and then redid any assessments that were done before that inter-rater reliability. We met weekly or every other week between our HPIO partners and our RAFI group to discuss the abstraction process to assure that we were each gathering information in the same way. And apparently Reem just responded that she got disconnected and they're calling back in. So Reem, feel free to speak up anytime you're back on board. In terms of the analysis, the analysis has to date been descriptive and associative. We have not done any regression analysis or more complex modeling up till now. That may be a part of our later analysis, but the key findings, I think, are apparent from these initial analyses.
Reem, if you're back on, would you like to comment on the question?
Sure, we're here. Sorry, we got disconnected there. So we missed part of what you said, Scott. Were there any aspects of the data collection aspect that you wanted us to address that wasn't covered with the hospitals, or?
Yeah, I think I commented already about our early inter-rater reliability efforts and our frequent meetings to assure that we were both collecting data in the same manner. That process also caused us to exclude several items that actually will be followed up on in the qualitative interviews that we discussed earlier. So that's what I shared with the group. If there's anything else that you wanted to comment on, please do.
Just one thing to note, and you did touch on this, I think, earlier in the presentation, but one difference between the hospital, sort of the availability of the documents for hospitals and health departments. We looked online, so if we could not find a CHNA or an implementation strategy on the hospital's website, we stopped there. So we didn't actually call hospitals to see if we could find the documents, which you all did for the health departments. And that's because, first of all, there are more hospitals than health departments, and we just didn't have the resources to do that. But also because there's a challenge in finding the right contact people within hospitals. So usually health departments have fairly small staffs, and it's easy to find the right person to contact. And a challenge in working with the hospital information is that the folks who are who take the lead on the CHNAs and implementation strategies in hospitals can be situated in several different departments. And so it can be hard to track them down.
And I would just add to that the majority of the hospitals, of the 189 hospitals where we didn't find a CHNA or implementation strategy for, were government hospitals. And there was some confusion around the rules for hospitals on whether or not government hospitals would need to comply with the CHNA and implementation strategy requirements in order to maintain or to get 501c3 recognition and status. And so that was clarified just in the final rules that were issued at the end of December. And so we may find that those hospitals really did not participate in conducting a CHNA or implementation strategy, but that they will in future years.
Correct me if I'm wrong, guys, but there is a requirement for meeting these IRS requirements that the documents be posted online. So it is reasonable to assume that if they weren't found online, it's likely that they weren't done.
That's correct. So that's for the CHNA. So for the community health needs assessment, there's a requirement. For the implementation strategy, however, there is not a requirement for it to be posted online. In fact, the rules are explicit in saying that hospitals do not have to post them online. And so that may be where we are in situations where a hospital may have had an implementation strategy or plan, but we would not have had access to it via just online.
Clarification.
Yeah, and they're also sort of a moving target. We noticed in a few cases a hospital had an implementation strategy posted, then it was taken down. They can be updated periodically. So it's a little bit trickier to compile for research purposes.
Yeah, and that's true for both hospitals and local health departments. The moving target aspect is an important limitation.
Yeah.
Thank you very much for the discussion. We have just a few minutes left. Is there one more question that someone would like to ask before we move on today?
This is Rosemary Chaudhry.
Yes.
I'd like to ask one if nobody else from the wider audience has been submitting one. Having coordinated two CHAs, and I guess I say this in the interest of feeling a little disappointed that local health departments didn't score better in many areas, particularly in assessment. And I'm wondering, Scott, if you can comment on if you have recall of the indicators that you found, particularly on the areas of health issues and specific descriptions of population groups with specific health issues are described. And the second indicator assessment in your slide is health issues and specific descriptions of medically vulnerable population groups. And I struggle with that medically vulnerable population groups, even as an expectation for a health department to address, given our population focus. But that being said, I'm wondering about, would hospitals have had more data, particularly in the area of ER use, patient utilization, that health departments might not have had and that hospitals might have used to meet?
Great question, Rosemary. I think that the differences in data that are available to begin with are substantial, though we certainly in public health have every opportunity to request such data from the hospitals. There are explicit instructions for abstraction of data in each of these areas. We will be happy to make that final tool available. Most of those specific instructions are based on the Wisconsin instrument that is already available in terms of how we determine these issues. But the final version of the quality measurement tool we used here in Ohio does have the explicit instructions, and we did adapt some of those based on Ohio characteristics compared to Wisconsin and other states. If they use the same tool, may need to adjust for themselves as well. It may be important also to note that this quality measurement tool can represent a guideline for the kinds of things that should be included in both CHNAs and CHIPs. There are other such formulations around, but one could assess for themselves using this tool whether they're meeting the quality metrics that have been described in this process and in Wisconsin's process. Finally, I'll say that the evaluation component of this project has been underemphasized in this presentation because so few hospitals or health departments had reached an evaluation stage in their process. So as you saw, the mean scores for the different components demonstrated in this project, the mean scores for the evaluation component on this scale of 0 to 4 were less than 0.5. So not many health departments or hospitals had entered an evaluation stage, and therefore, while it is part of the overall quality metric, it was not emphasized in our analysis, our sub-analysis of the different components of the tool.
Thank you very much for our presenters and our commentators and all the questions that we received today. It was a great presentation. I do want to direct you to the screen and let you know that archives of all the webinars are available at the web site listed at the top of the screen. Our next event is Wednesday, May 13th, violence and injury prevention, variation in public health program resources and outcomes, and we hope that you will join us for that event as well. So thank you to all the participants, presenters, and commentators today. Have a wonderful afternoon.